It is my pleasure to welcome. Especially, I would like to welcome some persons here. First off, I would like to welcome Christina Moore, the surgical technician from Bethlehem, West Virginia. Came all the way across the pond with none other than Herbert Oye, who is the consultant at the Valley General Cardiovascular Center in West Virginia, Bethlehem, West Virginia, United States, and he's the founder of the Oye Global Medical Foundation, as well as the chief medical director of the dialysis specialty. And also, we got the amazing people in-house, right? But because we want to be on schedule, I'm not going to go one after the other. Everyone here, thank you for your presence. It is raining right now, and I guess that's why we say we are from the waters, because, you know, it's river right? It's all water. But please confirm if you have any issues, you can hear us here, let us leave a chat in the chat box so that we can, know what you want to say to us. Yeah, thanks. So we're going to get started right about now. It's So, Crystal, I will be working with you throughout this event to make sure that we have a good connect and synergy from both ends. But I think we're good here and we can get started. So, without further ado, may I introduce to the podium Dr. Herbert Oye to get started.
Definitely welcome to our today. This set in the participating today here in Nigeria and say welcome to annual this from the innovator for thinking of having dedicated to the testing solution of the vascular knowledge, clinical judgments, is very important in the decision making. Our goal is to reduce the divide in the vascular care that experience in Africa and rural America. I'd like to say in the Start Debate program, it's a program that values both clinicians and non-clinicians. Roundtable discussion for necessary and video presented bring out the point. Our mission is to make endovascular surgery and care affordable and make it also not only in the US, but also in there's a big gap in vascular care between the US and Africa. We look forward to the robust numbers as educational, informative, and innovative. There will be thought-provoking discussions about healthcare, this kind of technologies that we use in surgery, in interventional cardiology. We look forward to the participation of this. And here from biopsy, where we had the first meeting 7 years ago, this is 7 years. I would like to say thank you to all the fellows, men and women, doctors, non-doctors on the video platform, on the personal platform, for joining us today. And I'd like to say thank you for the response. The Oye Global Medical Foundation, the Foundation, which also provides healthcare, the changes here in Africa. Civil region in the Salem hospital, that in addition will have the endovascular and the rings. this. For persons in medicine, real problem to suffer from the difficulty of ability to get care. And this, the ability of the woman to get care is often loss of life, the one loss of legs, it's very important that we do the right services that is there to educate, both of educate healthcare professionals. So we know that what in the vascular how to best manage the conditions and see them. So I will start off the presentation today by going through it. I didn't straight up some critical presentations about endovascular. When I say endovascular, what does that mean to you? Who's not endovascular? Many years ago, when at surgery at blocked artery, for example, in the midline, we do what we call bypass, meaning cut above the knee, cut below the knee, and tubing only pushes the between the blocked artery, and that's called bypass. So that requires making a cut. Now, endovascular surgery is minimally invasive. It does not require a cut. It requires you to needle, wire, catheter to achieve the same goal. So the good circulation of the body. Ready to stroke. For the brain to prevent strokes, for the upper extremities, the arms and lower extremity, the legs, and for the abdomen. Some persons walk around with what we call abdominal aortic aneurysms, where the artery in the belly bulges and sometimes can rupture, and it can lead to immediate death within a few minutes sometimes. So those patients require surgical intervention. In Nigeria and most African countries now, they will require most likely open surgery, where they'll be split open to repair the artery. With the advent of endovascular surgery becoming commercially available, dating back to 1997, you now can afford to treat some of these patients without major cuts. Wires through the aneurysms, balloons, and stents, and we're able to treat those patients in the US. So I've highlighted a few cases for to start up this discussion today, and if you will flip to those pictures, the one you showed me earlier, and I can go through them. Before I came in this time, I had in West Virginia. West Virginia, by the way, is a state of about 2 million people. It's just like the state of Bielsa. The only difference is the hospitals work, the roads work, and the government works. So we hope with time, the state of Bielsa would hopefully develop that point where you can have a hospital such as this where things work. The problem is it does not take rocket scientists to figure out health as well. No matter how wealthy you are, if you have bad health, you'll die. So it's important that we provide that health care. So this is an interesting case I'll start with. This is a patient, and we know in Nigeria and most African countries, if you have kidney failure, the very first thing they will say is, go to India, get a kidney. You go to India, you get a kidney. Sometimes in the rush to get to India, they don't fully give you enough preparation to ensure that the kidney you receive is the right kidney for you. So after they do the kidney transplant, they pump you with anti-rejection medications in India or any other country you go to. You stay there about 3 or 4 months. Then you spend lots of money. Then you come to your host country, such as Nigeria, and then 6 months later, you're dead. The reason is simple. The reason is not every person that has kidney failure needs to rush to get a kidney. There are ways to improve the kidney function of the patient where they can live and allow the transplant portion to be well worked out. So in the case I'll show you today, wow, it's still loud in it. The case I'll show you today on the screen is a kidney patient. Patient's on dialysis 3 times a week. And this particular patient, I'll take a little pause and raise here. Slow down a little bit. Here loud. Biopsy rain. Biopsy rain is serious. So please hold on. We have the biopsy rain here. It's torrential rain right now. Yeah, just hold it a few seconds and we'll try to have the rain slow down a little bit so you can hear me. So just give about a 2-minute pause. Okay. All right. So I'll continue then. So this is an interesting case of a real patient in Beckley, West Virginia, where I work. And this patient on dialysis. He did have a catheter placed in his right chest, a catheter for dialysis. So, you good? Is it showing? Is it showing? Is it showing?
No, it's not sure.
You have to make your phone before.
That he's working on it. Like it shows.
Okay, thank you. Go ahead. Shahreyar.
Dr. Oye, we can proceed as you were. We can still see the slides. If you can share.
Ready? You sure?
We can see.
Let me call the cleaner. No, leave it. We'll just come and sort it out.
We're trying to share the video with you, so give us a few minutes.
But ìtọ́jú ẹ lọ bá mi. Mo ti gbé àpótí gbogbo ẹ̀ wá sí ìta. Ẹ bá sọ̀tẹ̀ sí native àti English.
Good?
Careful not.
Can we continue? Yes? Okay. All right. The first case here is a patient who presents with a dialysis permacath on the right chest and also have an AV fistula and AV graft on his left upper extremity. You can see. You can see. That's my paper. You can see. So this particular patient, unfortunately, it was not possible to rescue his AV fistula on his left arm and required a new AV fistula in the right arm. So we took him to surgery, and at the time of surgery, we wanted to ensure that the right side was okay before we implanted the fistula. So our greatest dismay, we did have originally a permacath also in the right side. And you can see on that screen that it's immediate abrupt stoppage of blood flow at the top of the screen where that B is. So that's where the veins, the subclavian vein and the internal jugular vein meet. And you can see that. So there's no flow beyond that. The only reason why that has been like that was because he had a catheter, a dialysis catheter was going through there for an extended period of time. Next. So with that said, if you do an AV fistula on this fellow, it's not going to work because the outflow from the arm to the chest will be obstructed by the catheter, which is the white portion you can see here. This is catheter. So we're able to, in this case, go ahead and decided we were going to put a wire through the catheter, which we did. But because we were already in the right upper extremity up here, we decided to put a needle and wire through that area first. Then once we made sure a wire was going through the catheter here initially, and we're sure that the wire that crossed this block here. If you don't do that, and you just take the catheter out, there's a good chance you may not be able to make a wire go through at all. So first thing we did was put the wire through the catheter itself, then we'll put the second wire through the native vein, which is the subclavian vein right here. This is the active vein right here. So we were able to make both wires go down. Once that was in place, then we took the catheter away. Then next slide, we're able to identify again what the problem is. It's very significant. If this patient is found in dialysis today, there's no doctor in dialysis that can fix this problem. The only doctor who can probably fix this problem here would be probably at Dr. Adafe in Port Harcourt, maybe, okay? Or Dr. Nilo in Lagos. So there are very few people that can fix this for you, okay? So that being said, we're able to now thankfully make a wire go through that. And you can see on the other side, next picture, please. And so that again, that should do next please. Next please. Next please. So now you can see that again. Next please. You have the catheter there. Okay, now you can see the again. Go down this the heart, back, go down and straight. So our goal is to improve the flow. where the blue marks are. Next. And next. Then you can see the wire go through at this point. The wire that's coming from the right subclavian there. So now we're able to now take a special balloon, put that balloon over the wire to that target area, then we inflated the balloon to improve flow. One good news about Bielsa though, you need to be proud of Bielsa. Bielsa has the capability to do what you see there. Okay, the only problem is we need good partners in Bielsa to help us do that. But we have the tools to fix this patient. If this patient is a Bielsa walking around here, we have the tools to fix this patient right here in the operating room on the path. We do have the tools. So next. Okay, so you have another picture? Well, there's looking more pictures where that was ballooned, and you could actually see the flow better. Yeah, I guess you don't have it. But anyway, the take-home message, this patient's problem was fixed the balloon and that got better. And he was able to have an AV fistula on his right arm, and he was able to we then moved the dialysis catheter. That catheter then is neck, so it's groin because his left side was already occluded or plugged up. So we were able to now use that for 2 weeks in his groin. Then we took the catheter out. It was a graft. So the fish was able to take the graft thereafter. Next. Next one. Next case. Next case. So this is an interesting case of a renal patient or dialysis patient that you're able to rescue their problems without having to put them through big surgery. This fellow did not require major surgery to fix this problem. Okay. This is not a talk. Any questions from the any questions from you? In the meantime, any questions? Anything unclear? Any questions? Yeah. Are you good? What the? Can we have all participants on the virtual platform to mute your mics, please? So we don't have too much feedback. Thank you. So that's beginning. That's beginning. That's the first picture. Let's look at this one. So this is another case where it's a young lady, about 37, 38 years old. She's a renal patient, a kidney patient, has been on dialysis about 5 years. So she has an AV fistula, the AV fistula she's been using. So again, she's not on kidney transplant as a first choice. I know it's the best choice, but sometimes not. We don't have kidneys walking around the garage to go pick up the kidney. So we have to start them on dialysis initially through a catheter, then move them to a fistula, then AV graft if possible. Then ultimately, once they're fully worked up, they can get the kidney transplant either from family or from a non-related donor. So in this case, she's been on dialysis a while. She presented during dialysis with the fistula not working quite well. So she's not getting adequate treatment. So in this case, we brought her in and we stopped in the left arm. We stopped the fistula right here with a small needle, micropuncture needle, and we're able to take a contrast study, the venogram, which you see on the screen. And what's obvious in the study is you see an area that's really great. And there's a stent here already. You haven't measured before. So the stent has to block it. And also there's a lot of air down the stent. So we were able to easily, without any cut, put a wire through balloon that segment to improve it. Next one. And you'll see closely on the next, you're able to show them you can see the balloon going up right there. That's the stent that she had before. So we ballooned that stent, that improved. Okay, next picture, please. Okay. You see, you're going to the stent, balloon is going up. You can actually identify the area of significant stenosis or blockage. So that's this stenosis, I mean blockage. So that's right there. So the balloon goes up, and it's a special balloon cell. It's like fraction the area of stenosis, and it gets better. Next, please. And so it's up now. Next, please. Okay, much better right now. Okay. Okay, next. Okay. That's another thing. So in this case, it was an interesting case because we went in with the idea, anytime you have a fistula and you have a problem with fistula, so usually the problem is still at the chest. So you do the initial test, you shoot the dye, and you figure out the problem. It's still at the chest, so you know the problem. So we fix that problem here. But to be complete, we decided that's okay. To be complete, we decided to take a look on the lower portion, the arterial end of the fistula, and we discovered she had a problem there also. She had a stent there before, which we don't see on this picture. A stent there already, so we could not. We went back downstream, but we could not get into the stent. So we had to go into the patient's brachial artery and went this way into the stent, then put another stent for that to be better. It's not shown here, but it was an excellent result. So she's not had any problems since we did that. And that's the end of the story. No cut involved, just a needle, wire, catheter, and you're done. Okay? So I'll present one more case and we'll go international. That's the next one. So the next and final case I'll present as thought-provoking is this one. Very interesting. In Bielsa, in most African countries, we have persons that present with strokes. The reason for strokes are twofold. If you have a stroke could be because you have blood clot that's gone to your brain. That's 87% of the time. The other 13% of the time, strokes are caused because there's bleeding involved. So it's important when doctors, your nurses think you have a stroke, the very first thing they should do is do a CAT scan, correct? Because a CAT scan without any dye will tell the doctor if your stroke is due to bleeding or if your stroke is due to blood clot, because the treatments are totally different. If someone's bleeding and you give them blood thinners or blood clotting medication, you make them bleed more. So you don't want to do that. So in those situations, you give them, the neurosurgeon may be involved if necessary to take out the bleed in the brain. But if the stroke is from blood clot, then it's a challenge. We can get strokes and blood clots that occur, number one, directly from the carotid artery. The arteries on the inside of the neck. As we grow older, we sometimes generate plaque buildup in the neck area. The plaque buildup in the neck area is because the artery divides. Artery divides, as a result, there's turbulence around that area. So the turbulence can generate plaque with time. The other reasons why we'll form plaque buildup are genetics. If dad, mom have bad genetics, we tend to have it too. And if we smoke, which we don't do a lot in Africa, we tend to get a lot of plaque-related issues. Then sometimes some people may just have dietary habits that are very poor or bad for them and develop plaque disease. So in this particular case, this gentleman was an interesting case because he had heart problems, has had heart bypass before, has had 18 stents in his heart. That's a lot of stents. He's had 18 stents to keep him alive. He's 69 years old. So he shows up with this problem with about 95 to 99% blockage of the left neck artery, the carotid artery, and central carotid artery. So in this case, we felt nowadays we can treat this patient with stents, which is called TCAR, transcarotid artery revascularization. That's another stent. I did not want to give him another stent to make a 19 stent. He already has 18 in his heart. I didn't want to put a stent in his neck to make it 19. So we elected to do the standard carotid endarterectomy surgery. So we took him to surgery, made the incision in his neck, and we made the incision in his neck, and we took the plaque out from his neck artery. And you'll see in the image shortly, the plaque. And one reason why we did the surgery was on the CAT scan, it was described as an ulcer. It had an ulcer within his plaque. So when you look at the picture here, you can see the plaque in his neck artery right here. If you look carefully, you can see the ulcer with that. So he did have an ulcer. The ulcer in the carotid artery has blood. Remember, the carotid artery is here. Your heart's here. It's pumping the blood upstream. So blood can push the plaque to the brain, and you can get a mini stroke if it doesn't kill you. And you get a major stroke, and you can get major disability. So in this case, so it was a good thing we opened them up. You can see the plaque right there. Next screen, please. We're able to take that next screen. Again, right here, you can see, look at the back one. This is blocking right. You got to remind yourself, okay? So this is what hold on for a second. We were able to go ahead and take that off for a second. Take it off. Yeah, take it off. Okay, right there. We were able to take the plaque off. And after we took the plaque off, we noticed that he was bleeding generously from his internal carotid artery. So we used that as the origin for the episiotomy to open the artery. So after we took the plaque off, we put a patch in. The patch was nicely sewn. It looked really good. But when we unclamped, he kept bleeding from the internal carotid artery origin. So that was very troublesome for us. And we kept putting some stitches to slow it down. It just would not stop. And at the end of it, the internal carotid artery had been narrowed significantly. And we knew if they stopped at that level, he was going to have a problem with stroke after surgery. So we elected at that point to simply go higher from the area of his artery that was going to take the stitch. We went higher with the dissection, and we got an area above his hypoglossal nerve. So you're going really high. So we now decided at that point, you have two choices. You can either tie the carotid artery, internal carotid, the one that takes both of his brain away, and he will definitely get a stroke. Or you could do a bypass. So we elected to do a bypass. So we then made a cut. We're able to now sew a bypass to that area that was a little healthier in the artery. When the sew then with the bypass, then we'll have to bring the bypass to where the patch was. So this is the plaque here. After this plaque's removed, we sew a nice material patch. Then sew the bypass up there, up well, we burn the bypass there. But before we connect the bypass after the bypass after that area, we decided to take a shot, and that's what you've seen before. So we took a shot. I'm curious. I'm having this much difficulty doing what I've done, and this guy, do I know if he has a problem higher than where I was working? So I took a shot, and indeed found that his artery above the bypass had disease. This is at the same time with surgery. So that's the first picture you will see. Go back quickly, just quickly, you see that quickly. Go forward, quickly. Forward. This one, you can see my patch is right here and my bypass right here. So we have to now do something about that. So now, in the back of the surgery wise, the wires for that, put a little bit, that's after the so I'm now happy that carotid artery, when I open my clamp here, the blood starts to go up. I'm pretty sure this is than it was before. So now we then, at that point, connected the second portion of this bypass very soon already. We took the other portion of the short bypass to the capsule of the zone because so this was a very interesting case because not only did you do carotid endarterectomy, first of all, you started with a CAT scan that had a problem, 99% blockage of his left carotid artery. You proceeded to doing carotid endarterectomy because he's a high risk cardiac patient, had 18 stents in the heart already. And the reason why I didn't really went for open surgery because the CAT scan showed that he had an ulcer. So I knew that ulcer was a great problem of you getting blocked over the brain. So we took the plaque out with the ulcer, that solved the problem. Put a patch in. Then you now identify that, by the way, his internal carotid artery would not stop bleeding right above where you connected the patch. So we now did the bypass to the patch, and you have the final picture next. So again, this guy did well. After surgery, his hospital stay again was 1 day. One of the problems I see in Nigeria is people have surgery, they stay in the hospital for days on end. It's not necessary. The guy had surgery, pick it up. You go home the next day. Okay, so that's the way that worked out for him. So he did really well with that. So at this point, I'll take a break, and I will have some of our speakers, if anybody's ready from US. Anybody ready to give a talk? Who's ready?
Yeah, I can go
If
ahead.
you have any questions, please stop me. Any questions? Yes. Who's ready?
Sherry.
Yeah, first.
Aziz, I can go ahead.
Okay. Yeah, go ahead. Okay. Well, the reason why you have a blockage is, again, diet. What we eat, don't eat. In the carotid artery, uncontrolled high blood pressure is the reason, because blood flow is uncontrolled. You get the bifurcation here, division artery. With time, as we grow older, from age 50 and above, the turbulence can now start to create a plaque formation. In your board exams, they'll say, why do you have blockage in the neck artery? The answer is low shear pressure, SHER. So that's the reason why the type plaque. Again, if mom, dad have carotid disease, we have a 30 to 35% chance of having that type problem too. Okay. Then the bleed in this case was unique because he had heart stents before. He's on blood thinners to keep his heart stents open. Remember, he's had 18 heart stents before. So we did not want to stop the blood thinners to do surgery so it doesn't get blood clot and clot those heart stents. So we kept him on blood thinners still. But his artery was so diseased once we opened, he started to bleed from the beginning. So we used that interest to open to do the surgery. But after we did the surgery and patched it, it wouldn't stop bleeding from the clot. And that's the reason why we had to do the bypass to stop that problem. Okay? Okay. All right. So are we ready? Our next speaker ready? Okay. Yeah.
Yes, the first
So,
presenter is ready.
Are you ready to present next speaker?
Yeah, I can
If
go
you're
ahead
ready,
and
from your slide, please.
yeah, can you guys hear me?
Shah, it's Shah. It's Shah. Disha Shah. Disha Shah. They should be able to share. Yeah. Could you share a slide, please, Dr. Shah?
So I think I'll actually be going next. It's Aziz.
Yes, Dr. Aziz is going to go first.
Who's presenting first?
Can you guys hear us?
Dr. Oye, can you hear Dr. Aziz?
Okay. Yeah, I'll be presenting next. I just need the ability to share. It says sharing is not
Please,
turned
okay,
on.
Aziz. All right. All right. Dr. Aziz, just give us 1 minute. The rain is so loud here. So give us 1 minute, get your position ready, and also make sure you can share your slide. And once you can do that, then let me know, then we'll get you started. Okay?
Sure. Yep. Can you just
once you get
turn
there,
on sharing?
Take
Can the
your
host
volume
turn on
off so we
sharing
can
for
hear you.
us?
Okay, crank your volume up, Dr. Aziz. Are you ready? Make sure you're able to share the slide. When you're ready, just let me know.
Yeah. Can you hear me clearly now?
Okay, you want us to change, you want us to share the slide from here?
You
Okay.
just need
Yeah, we
the
can do it.
host needs
Okay.
to give us the ability to share, if that works.
Okay. Oh, that's what you're asking. Okay. What's gonna Gupta.
Well, I have the information though. Yeah, you have the information.
Doctor, can you hear?
Aziz,
Doctor,
Aziz.
please.
The problem is, Dr. Oye, that the students cannot share. They don't have permission to share their screen. So we're just working on that. Or if you can unlock them so that they can share. Dr. Oye, if you look in the chat, one of the students has written some instructions.
I just wanted to double check. Can you let us know if you can hear us, Dr. Oye, on your end?
Go ahead, I'm working with that.
This one you go by boom, a little by boom.
Maybe you go. Thank you. All right.
Can you hear me now, Dr. Oye?
I think their internet cut out. They're working on coming back. It's raining over there.
And accessible.
We can see you now, Dr. Oye. Video is back.
Crystal, is that Dr. Aziz, is that
Yeah.
you? Okay,
Yep, can
very
you hear
well.
us?
Okay, decrease the volume a little bit. Decrease the volume a little bit. Okay, so. We good? We have a lot of feedback. Okay, I'm a twin. All right, so. Dr. Aziz, you ready? Are you ready?
The host just needs to give us access to share.
Okay, very well. All right. We good? So, Dr. Aziz. Oh, boy. That's it. Hello? Hello? Yeah, that's better. So Dr. Aziz will be talking to us. Crystal,
Yeah, I
can you
just
make
need,
sure with Dr. Aziz again?
Yes, the only thing is he's unable to share for some reason on your side that it has locked anyone else from sharing their screen. So we're
Okay.
trying to figure it out. I'm trying to go into your settings and change it on my side. So I'm working on that.
Okay, I'll give you 5 minutes to figure that out.
Okay.
Okay,
5
we'll
minutes,
take a break
okay.
for 5 minutes, then you can figure that out. Oh, it's on there. We sent it. It's on there. It's on here. I gave it to you. It's on my phone. Yeah, it's on the phone. It's my phone. It's on my phone. No, she has since she has it. No,
Dr. Oye, did a password get sent to your phone?
fibrillation. It quivers so much, and it can generate clots in the chamber of the heart, and that clot can.
Dr. Oye, I'm gonna have to have the students email the presentations to you. If you can hear me, I'm not sure. Can you guys hear me?
Yeah, strokes from bleeding. So somebody falls sometimes, they get bad bleeding in the brain and they can get a stroke because they bleed in the brain, or bleeding that just occurs because high blood pressure is so high, the little arteries of the brain can just block open, bust. When it bursts, it can have bleeding, and that can also result in stroke. Okay, yeah. So when we get this access, okay, access. You said we can get access to. Oh. Let me just. Let me tell. Let me tell.
But that's what it's saying. It's not in general.
Okay. 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 That's fine. Whoever's ready is present. Let me tell you, at least it was ready. So, yeah. Okay. The email is fine. Yeah.
This is
only 3%. Then I'm pretty sure that what the politicians make is certainly more than what that 3% is. So again, our priorities are misplaced. Because our priorities are misplaced, we therefore have the masses that suffer. You don't need a rocket scientist to tell you that the healthcare system in Bielsa can be better. It also was actually better at some point. Unfortunately, the forces that are supposed to make it even go up and the trajectory have not played an active role, and therefore we've been stagnant for a while. So we'll take the commitment of everybody to make the healthcare system better in Bielsa. I'll take your commitment as nurses and doctors to ensure that your patients are well taken care of. Because at the end goal, it's not about me or you. The end goal is about the patient. And we speak this from a sense of personal loss. When your loved ones die because they don't need to die, it becomes a problem. Yeah. So who's ready? Okay, Dr. Azeez, we can transfer whatever you talk about here. So just go ahead and present. We'll go from there. Thank you very much, Dr. Azeez. We can see you now.
Yeah, awesome.
So
So
Dr.
I'll be
Azeez,
presenting.
Yeah, go
Yeah.
ahead.
Okay. All right, thank you. So I'll be presenting on critical limb ischemia, management in a rural hospital setting. And then there's a little bit of echo.
Can you mute Dr. Oye?
All right, I'll proceed now. So moving on to the abstract, which is the third slide. There you go. If you guys can move on to the abstract, it's the third slide. So critical limb ischemia is an advanced form of peripheral arterial disease that is constituting a major healthcare problem worldwide. Poor management and delayed presentation of patients with CLI can result in major amputations. The primary treatment strategy in CLI revolves around whether the limb is salvageable, worth saving, feasible for revascularization, and the risk to benefit ratio of revascularization. Thorough clinical evaluation, appropriate workup including ultrasound, CT angiography, and catheter angiography are essential in the preoperative planning. Enormous challenges in many rural hospitals lie in the availability of vascular surgeons and available resources for CLI treatment. Creative thinking outside the box and utilization of available resources and collaborative relationships with hospital administration are crucial for success. Next slide, please. So to give a little bit of background, critical limb ischemia is the most severe form of peripheral arterial disease in which significant arterial blockages lead to limb necrosis and gangrene. PAD affects over 200 million persons worldwide, with over 12 million Americans affected and over 200,000 amputations per year in the US alone. In certain global communities, amputation is the only and primary option. This reaches up to 65 to 80% of amputations in some developing countries. And next slide, please. So clinical presentation, these patients present with chronic ischemic pain, rest pain, ulcers, gangrene, and usually it's a minimal duration of 2 to 4 weeks. Next slide. So just to give some rough pathology, it involves atherosclerosis with advanced calcification of the vessels, and there's multi-segmental occlusions involved. This includes the aortic, iliac, femoral, popliteal, and/or tibial arteries. Next slide. So in risk factors, we have genetics, smoking, atherosclerosis, hypertension, and sedentary lifestyle. So as Dr. Oye touched on earlier, we have some non-modifiable risk factors like genetics, but this mostly makes up modifiable risk factors such as smoking, hypertension, sedentary lifestyles. And next slide. So treatment strategies, we have medical therapy, which can include statins, which are cholesterol-lowering medications, endovascular therapy, which has significantly evolved and improved since the 1990s, hybrid therapy, and open revascularization. And next slide. So our approach in rural West Virginia, the patient encounter begins with thorough history and physical examination, arterial Doppler studies, including ankle brachial indices, preoperative CT angiography, and then a catheter arteriography at the time of intervention, which is during the surgery. And this is for the evaluation of marked tibial calcifications. Next slide. So when is endovascular therapy necessary? It's to improve blood flow to the fem-pop regions, to provide straight line flow in order to improve chances of limb salvage, to balance a risk-benefit ratio of prolonged intervention, contrast to patients with comorbid conditions. This is to avoid distal embolization during endovascular interventions and aggressive interventions to solve distal embolization issues. Next slide. So some vascular access considerations, we have contralateral or ipsilateral common femoral artery access, retrograde popliteal access, pedal access, brachial access, radial access, and axillary access. And I'll touch on this again with a case that I'm going to show you guys. Next slide. And so I'll go over some treatment options and cases. And next slide. So I'll go over some cases we have here to present, such as balloon angioplasty, stenting, atherectomy, thrombectomy, and then a hybrid therapy that we also do. And next slide. So in our first case, we have a plain balloon angioplasty. This was a 33-year-old female with severe right common iliac artery occlusion. Our plan was endovascular therapy for angioplasty and stenting of the common iliac arteries. So on the left image, you can see this patient had severe occlusion of the right common iliac artery. And in the middle picture, you can see our process of ballooning the angioplasty. And to the right, you can see the stent is placed and we have perfusion restoration. And next slide. So now we have a covered stenting. This was an 82-year-old female with right common iliac artery occlusion. Our plan was right common iliac artery cannulation from the left brachial approach. And on the right, you can see complete occlusion of the right common iliac artery. And this was a really interesting case because we attempted a retrograde common femoral artery approach, but due to excessive calcifications, we weren't able to proceed there. So we had to make the call intraoperatively to proceed with the left brachial approach, which is the left arm. So we had to prep that arm. We went with that approach, and that was successful. As you can see, towards the right, we have perfusion restoration. So that was a really interesting case and a good example of having to be creative in the operating room. And next slide. So next we have an atherectomy. It's a 78-year-old female with plaque obstruction of the right fem-pop region. And our plan was atherectomy of the right fem-pop region. You can see a picture of an ulceration on the foot. And there's severe gangrene here. And you can see some thrombuses that were removed. It's a good image there. And then next slide. So we have percutaneous mechanical thrombectomy, a 34-year-old female with severe right brachial artery occlusion. Our plan was percutaneous minimally invasive thrombectomy. You can see a picture at the level of her antecubital fossa where there was a clot and plaque obstruction. And we were able to do a thrombectomy to remove this. This patient most likely had a PICC line, which increases her risks for thrombus formation. And next slide. So now we have hybrid angioplasty, stenting, and embolectomy. This was a 69-year-old male with fem-pop plaque obstruction and clotting. Our plan was hybrid therapy with a retrograde popliteal artery approach. So you can see at the level of the popliteal artery, we have an occlusion here. And through angioplasty, stenting, and embolectomy, you can see all the clots and plaques that were removed to the right. It's very extensive, but in the end, we had perfusion restoration. And next slide. Here we have an example of hybrid angioplasty, stenting, and thrombectomy. A 55-year-old female with right limb aortofemoral bypass thrombosis stenosis. Our plan was thrombectomy and stenting. I included an image of her CT, which we do preoperatively to kind of get a blueprint of the area we're working in. You can see there is occlusion to the right, and you can also see that on the arteriography, there's a right common iliac artery occlusion. And we proceeded with ballooning, stenting, and thrombectomy, and you can see perfusion restoration towards the right. And next slide. So here we have a fem-fem graft revision. This was a 73-year-old man with the femoral bypass stenosis, which is not uncommon in patients who have grafts to need to be revised. So our plan was graft revision and thrombectomy with embolectomy. And I included his CT on the left. You can see the occlusion and the graft we had to place to bypass. And in this, we had to revise the graft. you can see the occlusion in the arteriography, the really nice image of the stent being placed, and then the perfusion restoration with the stenting. And next slide. So as I was talking earlier about the access points we have, this is a great example of that. This was a graft revision access point, an example of graft revision access points. So we have multiple access points due to intraoperative clotting complications. Our plan here was thrombectomy and stenting. So as you can see, we have an access point in the femoral area, popliteal area, and dorsalis pedis area. This patient clotted extensively, so we had to go with multiple access points. And you can see to the right some plaques and thrombus which were removed. Next slide. So here I want to talk about the basal trial really quickly. It's a bypass versus angioplasty and severe ischemia of the leg trial. And what this trial showed us was that endovascular therapy appears equivalent to bypass. One limitation at the time was that plain balloon angioplasty was the only method for endovascular therapy. At the time, there was a 20% technical failure rate. Our results are better now because we have improved balloon profiles, as Dr. Oye was talking about earlier. And we also have access to intravascular lithotripsy. And this trial also found that bypass is much more debilitating. Next slide. So the take-home message here, CLI treated with endovascular therapy has high technical success rates, over 90%, a low peri-procedural mortality rate, less than 2%, low complication rates, less than 5%, and a 1 to 2 year limb salvage of over 80%, which is great. Next slide. So in conclusion, endovascular therapy is useful in the management of CLI. Hybrid open revascularization options can provide great success in some advanced cases. Rural hospitals face financial difficulties with capital investment for CLI programs. Vascular surgeons in rural settings must have creativity to make interventions feasible with limited resources, like that left brachial approach we spoke about earlier. Vascular surgeons and rural hospital administrators must have financially prudent strategies to make CLI programs viable. And that concludes the presentation. So thank you. And then if there's any questions from Dr. Oye's audience. And if there's no questions, the next person can go ahead and present.
All right, can everyone hear me? Yeah, we can hear you, but there's an echo. I sent my PowerPoint.
Now, hold on a second.
Yeah.
Are you there? Can you hear me?
Yeah, I can hear you.
Is that a yes or no? Is that a yes? Is that a yes? Okay.
Yeah, we can hear you now.
Okay. What I need to do before you start, Aziz, is Dr. Kiran. Dr. Aziz gave a very nice talk, but I want the audience to understand the fundamentals of what he presented. Again, the take-home message and was very great. Number one, critical limb ischemia is that situation where you have a circulation problem with your arteries that's causing blood flow reduction, making sure you don't have enough flow to your legs or to your arms. That can result in you getting an amputation. That's why it's critical. If you don't treat it, you will lose your leg and arm. Okay. If you come to a hospital and you see a doctor with a leg pain, and the doctor says, Mrs. Jones, you're fine. And Mrs. Jones, you've been having this pain for 4 weeks, and Mrs. Jones, your leg's not very fine, and you go home because you believe the doctor says everything's fine. There's a good chance that if you have critical limb ischemia, you can lose your leg. So again, it's not only important for doctors to understand and the nurses to understand what critical limb ischemia is, it's also important for the patients and their families to know what critical limb ischemia is, because if you don't, you will lose your leg. You will be one of those persons walking around in Nigeria with the leg missing. That's the reason why it's important. Okay, we do we spend a lot of time, a lot of attention to ensure people don't lose their limbs. Okay, in the U.S., I live in a community, work in a community that's like Bielsa, but it has everything I need to work. I do work that you will find in New York, in London, in Tokyo, because the hospital is invested in making sure the tools that we need to work are available. Okay. Now, endovascular surgery in that community in West Virginia, I have done in several hospitals since 1997. So I have made it easy for persons not to lose their limbs. If a patient loses a limb under my care, is because there's no way out. They came way too late, or it's just bad luck. Okay. But we can make critical limb ischemia less likely in Nigeria, because just like you have in the US, you have in Nigeria. I go to different hospitals in Nigeria. It is there. I just left Lagos 2 days ago, worked hard in Lagos on Wednesday with somebody quite educated with critical limb ischemia. We operated on him from 3 o'clock in the afternoon to 10 p.m. at night in Lagos. He went home the next day, which was yesterday. I can tell you, ordinarily, if a patient comes to most hospitals in Nigeria, he'll be there for a week, 2 weeks, 3 weeks. He traveled all the way from Enugu, went back to Enugu yesterday. So that's what I'm talking about. When I talk about being able to provide healthcare that transforms our healthcare system, that's what I'm talking about. Because I work from a community hospital that is community hospital, but we do great things there. I want to bring that technology. I've been bringing that technology back to Nigeria over the years. And by also, on one of my trips, I had somebody come from Warri, had surgery here at Bielsa Special Hospital, and went home the next day. It is possible to do it. Okay, we just need our doctors to be vigilant. We need our nurses to be vigilant, because it is you that will identify the problem. The patient comes to you with a problem. Not every person that comes to you has malaria and typhoid. That's the question. You have to understand that sometimes beyond malaria and typhoid. Okay, so otherwise, your family, if you're here today, you're going to hear this, and when your family member has a leg problem, somebody's going to register. Could it be the artery that's bad? Okay, if your artery is bad, you lose your leg. If your vein is bad, you have a vein clot, chances are you're not going to lose your leg. You'll have pain. But if your artery is bad and really bad, everybody in this room today, if you go home today, all of a sudden you have leg pain you never had in your life. Your leg is cold, it's painful, it's numb. You have a circulation problem. You don't have to be a doctor to figure that out. What you need to do is find the right doctor to fix your problem. If you have a window, what we'll call relative ischemia and absolute ischemia, you have 8 hours from the time your leg pain starts. 8 hours where if a doctor sees you that can fix your problem, you have the chance that your leg pain will go back to normal. Okay? If they don't fix it right early on, there's chances that after 8 hours comes absolute. If for any reason, for doctors here, if somebody comes to you about leg pain, the very first thing you should do is check their what? Pulse. Do they have a pulse? You already came to you because they have pain already, so they know they have pain, but they may not be able to check the pulse. So you check the pulse. If they have a pulse, good. If they don't have a pulse, they have pain, their leg is numb. As a doctor or nurse, you tell them to wiggle their toes. If they can wiggle their toes, that means the blood flow is still going to their toes. If they cannot wiggle the toes involved, that means it's bad. You have absolute ischemia. That person has a high likelihood of losing their leg. That's a fundamental issue, okay? So critical ischemia is very important. Okay, now if somebody comes to me, they've been having leg pain for 6 months. That's the way they've been for 6 months. Then I ask them, okay, anything's changed? No, but I've been there for 6 months. They may have chronic ischemia. I don't need to rush to operate on that kind of person, because you need to do a CAT scan first, see exactly what the problem is, okay? Then figure out how to treat them, okay? Not every person has a blockage needs the operation, but sometimes when they need the operation, you don't do the operation, they will lose their legs. That's the take-home message. Got it? Okay. All right. So, Dr. Amogh, you are next. Go ahead and give us your presentation, please.
Sounds good. So I believe I sent it to Herbert Oye 2022.
Are you ready?
Yeah, I'm ready. So yeah, I believe I sent it. It's still disabled in terms of sharing. So I sent it to Cynthia and yourself, I believe. Okay. Yeah, I see that now.
Just one second. Dr. Oye, can you see your phone for 1 second? I sent a quick instructions to see if you can enable the sharing and see if see if it can work.
Dr. Morgan, go ahead. You can present.
Okay.
You're muted. You're muted. You're muted.
Yeah, can you hear me now?
We can hear you.
Okay, sounds good. So it still says it's disabled to share screen. But yeah, I can see it on the main screen. All right, so I can start off. All right, so my presentation, I kind of based it off a case that we had 2 weeks ago, but also based on an article from the Journal of Vascular Surgery, and the article's title is Clinical Impact of Anemia in Patients Undergoing Endovascular Therapy for Peripheral Arterial Disease. So yeah, just for a brief introduction, here's some epidemiology of peripheral artery disease. It affects 7% of adults in the United States and more than 230 million people worldwide. And of the people who have peripheral artery disease, anemia is present in 47 to 75% of these patients. And studies have shown that having anemia present does impact patient outcomes. Below this, you can see kind of a chart organizing some of the more common causes of anemia. I'm not going to go through all of them, but you can see microcytic, the most common would be iron deficiency anemia or anemia of chronic disease. And then normocytic, you kind of have to differentiate between whether the reticulocytes are compensating or not. But the most common cause here would be blood loss, which is pertinent to our case and surgery in general. And then you have the macrocytic anemias, of course, which can occur with liver disease and vitamin deficiencies. So this is the case from the Journal of Vascular Surgery, and it's a retrospective cohort design. And the main goal of this study was to figure out how anemia impacts 30-day mortality in patients undergoing endovascular therapy. So their primary outcome that they were measuring was the 30-day mortality, but they also measured the length of stay. So just briefly, you can see the patient demographics here. They had quite a few patients who they incorporated within their data, and they then stratified these patients based on their hemoglobin levels. So you can see anemia in this study was documented in 48%. I know earlier we were discussing that like in general, the range of anemia in patients with peripheral artery disease can range anywhere from 45 to 75. But in this study, it was 48%. You can see they stratified mild, moderate, and severe. And then in terms of their primary outcome, their 30-day mortality odds ratio in patients with and without anemia, they found that even mild anemia did correlate with an increased 30-day mortality. And you can see it jumps significantly once you go into the moderate range, which is 8 to 9.9, and then the severe range, which is a hemoglobin value of under 8. Which corresponds to almost 3 times higher mortality rate at a 30-day window than patients with no anemia. No anemia would be classified as hemoglobin above 13. So here's some more background in general, which is more relevant to our case, which I'll be going over later. This is just some background on fistulas. The most common use for fistulas are to increase the flow rate, which is needed for patients undergoing regular dialysis. However, fistulas are notorious for eventually not working. They can get occluded, which can lead to color changes around the AVF and also increased warmth. You can start to see an increase in purple to red color. And eventually this can lead to, a problem with the patient being able to get dialysis, which can then, lead to a whole other slew of comorbidities, particularly electrolyte abnormalities, which can arise when a patient is not able to get dialysis. So below, I've listed some other complications of AVFs in general. Pseudoaneurysms can arise from AVFs. And this is, in fact, the most common etiology when you see a pseudoaneurysm. It's usually around the site of an AVF. You can get an arterial steal as well. You can get venous hypertension, so you can start to see varicosities develop when an AVF gets occluded. And you can also, see a rupture within the AVF, so kind of leaking outside of the vessel. So like I mentioned before, AVFs fail at a pretty significant rate. The immediate loss of an AVF is around 12.1%. The 3-month loss is 26.6%. And the amount of AVFs which stay patent after 6 months is 71%. And patency after 1 year was found to be 62.6%. And then that's just a figure showing some of the common sites of the anastomosis between the artery and the veins in the upper extremities. In our case, will be in an upper extremity. So yeah, we'll get to the case now. So our case was a 69-year-old female with a right brachial cephalic AVF, like her fistula was occluded, and she was unable to get her dialysis. So she came in to get a revision of that, her AVF. Some brief history, because I do think it's pertinent for her because she does have a lot of risk factors for PAD. As mentioned from our last presentation, some of the risk factors include, for PAD, include type 2 diabetes, and then hyperlipidemia, which this patient had. And other risk factors can be smoking and sedentary lifestyle, poor diet, a high fatty diet as well. So several risk factors there within our patient for PAD. And of note, when she was admitted with borderline severe anemia. As you know from the previous slide, severe anemia is classified as hemoglobin under 8. And she was also found to have varicosities proximal to her AVF. So prior to surgery, she was given 1 unit of packed RBCs, and we went ahead with the surgery with a preoperative diagnosis of a clotted PAD.
I don't care for this team. They're follow 21. They're not like with American. So they choose to come out.
Sorry, what was that? Okay.
Continue.
So, okay. So yeah, that was the preoperative diagnosis right there. So we'll get to the images now on the next slide. So although I did mention we were handling the AVF during the surgery, we also saw that the subclavian had poor flow here. So you can see kind of the first image, the one that's on the very left, was prior to the ballooning that we did. The center image is the balloon going up. And then the balloon ended up we weren't satisfied with the flow that we were able to produce with just the balloon alone. So then you can see here, there's in the rightmost image, we did end up stenting, and you can see the blood flow is a lot more robust in the left image compared to the one, or sorry, in the rightmost image compared to the one in the most left. And then next slide will show the site of her AVF. And so not only did we put in a stent here, so the left image is pre-op, the right image is after we did our interventions. So you can see here, not only did we put in a stent, but we also, during the operation, had to superimpose her prior graft at the AV site because there was the graft was not working properly. So yeah, you can see here on the where my on the right image on the more inferior vessel, that's the site of the graft that we placed. So yeah, there, and you can see there the blood flow is a lot more connected and uniform compared to the image on the left. So the right is after our interventions. So you can go to the next slide. So yeah, so this is basically the conclusion side. I wanted to point basically her post-op course and also point out some take-home points incorporating our journal along with the case. So yeah, the patient surgery, I guess the major complication of her surgery was, she was already going in with anemia, and during the surgery, due to the loss of her prior graft, she ended up losing even more blood. So actually, post the angioplasty stenting, although we did get robust blood flow, her hemoglobin did drop to 6.7. And if you remember pre-op, it was 7.9. And so then we again transfused with 2 units this time of packed RBCs, and her hemoglobin returned to 9.9. Now that's not optimal, but in this patient, that was near her baseline. She was chronically around a hemoglobin of 10 due to her prior history of thrombocytopenia. So even on her prior admissions, she would always come in with a baseline of 10. So so then that's basically what she was discharged at 2 days after her surgery. She was discharged with a hemoglobin of 9.9. She returned to our clinic the next week. I actually got to see her. So that was this week, actually. And yeah, she was doing great. No further complications. The site of her AVF looked good. And I guess the take home here would be we need to carefully monitor a patient's hemoglobin, as studies have shown that it can significantly increase morbidity and mortality in patients where the hemoglobin is under 10. However, it's also important to stratify because when the hemoglobin drops below 9.9, for example, which would indicate moderate anemia, or when it drops below 8, which would indicate severe anemia, in those two risk groups, you have a very significant increase in 30-day mortality. As I had mentioned before, the odds ratios goes up to close to 3. So I guess, yeah, the take home here, maintaining a hemoglobin over 10 will not only reduce your length of stay, but will also increase or decrease 30-day mortality in patients undergoing endovascular therapy. Yep, that's it. Thank you.
Dr. Mark, can you hear us? Yes?
Yeah, I can hear you.
Can you hear me? Yes, is that a yes?
Yes, I can hear you.
Okay. Okay, very well. Now, thank you again for the nice presentation. For the audience, any questions from the audience? Any questions from the audience? Again, it's important if your patient's going to have surgery that you make sure they're not too anemic, because if they're too anemic, and depending on the type of surgery you're performing, if they're too anemic, what's the biggest risk factor that can occur? Anybody? Cardiac. They'll get a heart attack. Okay, if they're too anemic and you don't register they're too anemic and you just push on, if it's not a dire emergency when they're not dying, it's better to correct the anemia. If you don't, and you just take someone with anemia of 6.7 and you go give them anesthesia, they may just not make it off the table. So it's important that you correct that anemia somewhat if it's not a dire emergent surgery, because the stress in the heart can result in cardiac event, heart attack, or death. So it's important that you know that. Again, most renal patients, as we know, do have may present with a lower level of blood count. Some of them are well compensated at that level. Even at that, because they're going to be having surgery, that additional stress of surgery is what we want to minimize. So that if th're really, really low, we get to augment them a little bit before they undergo surgical interventions to take a message. Yeah. A nice presentation, Dr. Amogh. A nice presentation. Thank you so much. Who is our next presenter? Do you know? Joyce? Okay. All right. Thank you so much. You can hang on and see if you enjoy the rest of the conference. Appreciate it. Yeah, our next speaker is Joyce. Yes, Dr. Joyce.
Oh, I'm sorry. Can everyone hear me and see me clearly?
Yes.
Okay, great. Good morning and good afternoon. It is my honor and privilege to be here with you all. And I'm so honored to have been working with Dr. Oye here in West Virginia. I don't know if you have my PowerPoint.
They have it. It should be there.
Okay. Okay. So
The purpose of this conference this year is empowering our young physicians of the future. So as you can see on the screen, we've had a lot of young physicians present to us today, and we're trying to engage them to do so, because that is some of the things they would need when they pursue added qualifications and residencies, fellowship, and the like. The ability to add what they're doing today to their curriculum of activities would be very helpful. So again, they are the future of medicine, so we'll give them the opportunity. And we'll also look forward to young physicians here in Nigeria and other parts of the world who are part of this conference today to become engaged in presenting interesting cases of yours. We also have the global ground rounds, which we present every 3 months from Berkeley, West Virginia. It's a global event, it's virtual. So if you have an interesting case in Nigeria, it doesn't matter where you're in Nigeria, or Ghana, or Cameroon, whatever, India, you want to present a case, you have an opportunity, like doctors are going to be presenting now, to present so you can share whatever take-home message you have for the audience at that time. Our next Global Ground Rounds event is scheduled for December, I believe the first week of December, first Saturday of December. Again, I'd also like to thank our other sponsors, Uzuma Foundation, as well as the Oye Global Medical Foundation and the Edward B. Dietrich Vascular Society, for giving us the platform to present today. Do I have everything ready for Dr. Joyce? Just a minute, Dr. Joyce. Again, the Edward B. Dietrich Vascular Society was the society created by my trainer, Dr. Edward B. Dietrich, a vascular surgeon and cardiothoracic surgeon, vascular surgeon, who was our pioneer in vascular surgery and in the vascular surgery also. He was the founder of the Arizona Heart Institute. He passed away in 2017, February, but he has trained in his lifetime so many residents of my caliber, and we're so grateful to him for giving us the opportunity to do so. He was able to train two physicians from Senegal, Dr. Mohamedou Ndai and Dr. Papa, and they came back to Senegal and doing great work in Senegal. So again, it has trained many doctors from all parts of Europe, the South America and America, as well as Asia. So Dr. Dietrich was a mentor, and we continue like that. So now Dr. Joyce can present. Okay,
Yeah.
we're ready? Okay, Joyce, go ahead.
Yes. Hi. Thank you, doctor. Thank you for that. And
Here you
I
go.
will be. Could you hear me?
Yes.
Okay, great. So I will be presenting the bilateral subclavian vein stent and AV graft, what Dr. Oye spoke about earlier today. I don't know if I could top it. He did such a wonderful job. So my next PowerPoint, thank you. So here in the United States, like Dr. Oye was saying, chronic kidney disease is very high. More than 1 out of 10 Americans have it. The estimate is 20 million to 30 million, and more than 1 million being treated for end-stage renal disease, and more than 400,000 on hemodialysis. Next one, please. Okay. So here we could see that the difference between an AV fistula versus an AV graft. The main benefit of having the AV graft is that it could be used for hemodialysis in little as 24 hours after creation. So this was very great that we did this on this patient. So the next one, please. Thank you. So here are some of the symptoms that we could see in a subclavian vein. We can see arm swelling, we can see discoloration and soreness, we can see risk of venous thoracic outlet syndrome, which we all know is caused by compression of the subclavian vein. And here we see in this patient who was 54 years old, he had a really the cephalic vein and the basilic vein was very compressed. Yeah. We can go on to the next one. Okay, thank you. So here, the past medical history of the patient, he had diabetes mellitus type 2. He had coronary artery disease with a post-coronary artery bypass grafting 3 times. And it had hypertension, hyperlipidemia, hypothyroidism, huge, like what Dr. Oye was saying here in the United States, is tobacco dependency is very big here, and GERD. And he had history of opioid use and was on Suboxone. His end-stage renal disease, as we spoke about, and he was on hemodialysis. Next, please. Thank you. So as we see here, this was the procedure that we did. Right arm AV graft with a 4 millimeter by 7 millimeter and 45 centimeter graft cortex. And also we had a venogram of the right subclavian vein with 10 millimeters by 4 centimeters conquest balloon and a 12 millimeters by 4 millimeters atlas balloon. Also, we had an angioplasty of the right subclavian vein with 10 millimeters by 4 centimeter conquest balloon and a 12 millimeter and 4 millimeter atlas balloon. Also, we did a deployment of the 13.5 millimeter by 4 centimeters Fluency Plus covered stent and a 12 by 4 centimeter Fluency Plus covered stent to the right subclavian vein. And finally, we did a perm cath tunnel catheter placement at 28 centimeters right femoral vein. Next one, please. Okay. So here, yes, we have it here. So past surgical history that the patient had, he had several surgeries. He had open reduction and internal fixation of the left leg. He had 3, as we spoke about, vessels, CABG. He had a cardiac catheterization with stent placement. And finally, he had a debridement of bilateral foot wounds. And that we can see very highly in patients with diabetes. So it's very important to check peripherally, like Dr. Oye said, to check the pulse, number 1. So it's very prevalent for that. Next one, please. Thank you. Okay, so the next slide, we're going to see details of the procedure case of the 54-year-old male. So we first obtained informed consent. We timed out, we checked the neck and the chest and prepared it with a chloroprep. Real time, we really did the ultrasound, which was really gauged us and to see with the cephalic vein and the basilic vein, and we noted that it was quite small, so it was occluded. So then afterwards, we went to the right upper extremity, which was due to occluded of the left upper extremity AV graft, which was what we decided to do. We proceeded to make an axillary incision to expose the axillary vein and artery, which were robust in size. Then afterwards, we used a 4x7 millimeter Gore Tex graft, which tunneled to 25 centimeters. Then we gave him a 5,000 unit of heparin initially, and then cut the graft end to match the artery. Next, please. Then we continued with the venogram, demonstrated that the subclavian vein had an occlusion, and mostly at the junction of the internal jugular vein, which was completely occluded, and the subclavian vein on the left also. So we decided that the patient had, and we knew he had a pre-existing perm cath, so we did locate it, and we guided the wire downstream with a 10 French sheath in the right axillary vein. The perm cath was then removed, and we did the angioplasty performed with a 12 by 40 millimeter conquest balloon, which advanced to 10, then repeated to 13.5 and 4 centimeters. A cover stent was placed and an overlapping stent of a 12 by 42 millimeter due to the severity of the stenosis. Then we checked, and there was a good flow, which was achieved afterwards. So that was a really great sign. Next, please. Thank you. So the venous end of the graft was matched to the vein and repaired with a 6:0 proline suture in running matter. So the arterial venous blood flow was noted to be working. So at that time, we knew that this was going to be great, and Dr. Oye did a really good job. The right groin was prepared with chloroprep. The right common femoral artery was cannulated with a microvenous needle. Guide wires and sheath, which included with serial dilation and guided with the guide wire to the inferior vena cava, resulted with a successful flush with both ports and good flow without complication. Next one, please. And here we could see that the complete, where the arrow is, you could see where the arrow, that the complete occlusion of the balloon was right there. Okay. Next one, please. And here is the continuous of the angioplasty that we did of the right arm. This is the specific size that we used for the stent, the AV graft, the 4 millimeters by 7 millimeters by 45 centimeters. And then we had the angioplasty of the right subclavian vein that we used a 10 by 40 millimeters by 4 centimeters with a conquest balloon of a 12 by 4 millimeters Atlas balloon. And then you can see here a deployment of the 12.5 4 centimeters covered stent and a 12 by 4 centimeters. Next one, please. So I did some few research here. This was a very interesting and amazing case. And first of all, it's really important to see and begin with the AV full study of the access to see where the stenosis is. The covered stent may offer better long-term patency estimate, which is a 50 to 75%. This is the research that was done. And also, this was a great discussion afterwards that Dr. Oye taught us that if there's deep scar tissue, that this would lead to a needle, a thicker needle to be used. And also a stiff guide wire into the IVC would help for better support, also giving the heparin. And these are the guidelines of the balloon measure. And we have here that the balloon angioplasty, if results in a recoil, we prefer to re-balloon most likely. And if need be, the end would be to stent placement. And if a rupture occurs, this would be treated with a prolonged inflation or a stent and then a covered stent. And the treatment in conclusion is important to achieve access superiorly and inferiorly, which involves the groin access, and to make sure that we get a full bilateral picture of both of the sides of the groin. And that briefly concludes us. The patient recovered very well, came to the clinic, and did really well. And that is all. Thank you so much for having me. If anyone has any questions.
Questions from the audience? Okay. Any questions? It's the opportunity to ask the expert there, if you have any questions. Because I will ask you if you don't have it. I'll pick on you if you don't have as. Okay, very well. But anyway, Dr. Joyce,
Thank you.
it's important, again, for the audience to know when you say a covered stent. They may not know what a covered stent is. So we know there are two types of stents that we implant in patients. Either it's a plain stent, which is just either nitinol stent or steel, bare metal steel stent, versus a covered stent. A covered stent has a material that covers the stent, so it kind of gives a little more integrity to the stent. And so if you have little tiny blood clots, they don't escape through the side holes of a plain stent. This particular stent that we used in this case, I like using it because it has a great tensile force. So when you inflate the balloon, it keeps that area of the stent open much longer than a regular plain stent. So at the level of subclavian vein and at the level of iliac arteries, if I have complete occlusion of subclavian vein or I have complete occlusion of the iliac arteries, if I'm able to cross that area, I prefer to use a covered stent at that level because it gives me a much better patency in the long run. So that's the benefit of covered stent. Again, we also need to know that when you do the AV fistula creation, typically when you connect the vein to the artery, you have to wait anywhere from 8 weeks to 12 weeks, meaning 2 months to 3 months before that vein can be stuck for dialysis use or encounters. The reason being you have high flow, arterial flow going to the vein. The artery is thick-walled and the vein is thin-walled. So when the flow from the artery goes into the vein, over that time space, the wall of the vein now thickens like an artery and is able to withstand the pressure. When they stick the needle for dialysis, it does not, infiltrate or rupture. Okay, one of the things that you see in your dialysis centers in Nigeria, they do a lot of AV fistulas. It's important to tell your technicians that they don't stick the same hole all the time, because they keep sticking the same hole all the time, the patients will develop a pseudo-aneurysm, like big bulge around the area been sticking, and sometimes that can become problematic for the patient. Again, for the young doctors, you work in the emergency room, a patient's on dialysis, and they come to the ER with bleeding from the AV fistula, just got up from dialysis, then AV fistula is actively bleeding. Those patients, you literally don't get excited, get 5-0 Prolene sutures, 5-0 Prolene sutures, and just do a U-stitch, just minimal underneath the skin, and that will control the bleeding. Otherwise, you have the patient bleeding, and it can bleed out and use towels, which is not effective. The best treatment is put your gloves on, put a couple digits right over the bleeding hole, enough to put pressure for you to put that little stitch. It will stop the bleeding immediately. Patients have been known to lose a lot of blood because the healthcare professionals managing them just don't understand that you don't need to put a big towel. You need the digital pressure for more effective pressure. So it's important. So if you have somebody who's on dialysis, biopsy, for example, come into the ER, the active bleeding, do not get excited. Put 1 or 2 fingers right over that area, find a small suture and put a stitch. It will stop bleeding. Then you can wrap the patient up. Okay. Thank Dr. Joyce. Nice talk. And thank you so much. We'll chat later.
Thank you for having me. Thank you, everyone.
Okay. All right. Who's next? Temi's ready? Who's ready? Okay, Aslam.
Yes.
Okay, Aslam is ready. All right, our next presenter. Aslam, what are you presenting up to us today? Can you hear us?
Yeah, I can hear you.
Oh,
Temi
you
and
both present. That's right. You're the twins. Right, you're the twins. Okay, you have the Nigerian twin on the right side, and you have his counterpart on the other side. Okay, they are my young students. Dr. Temi went to Babcock University here in Nigeria, and about 3 weeks ago, I was working with him doing a carotid surgery, and I was asking him a few questions on the surgery, and he kept getting answers right. So I finally turned out to him and say, "Did you do anatomy for first degree, or did you do anatomy before?" Because his answers were very great. I was glad for him. He said yes. I said, "Well, where did you go to college?" He says, "Babcock University." So one up for Babcock University. All right. But anyway, they will present to us today some exciting deal. I'll let them introduce their talk.
Sounds good. So, yeah, whenever you're ready to pull up the presentation, we should be good. All right. So good morning, everyone. Thank you for joining me today. My name is Aslam Hussain, third-year medical student of Avalon University, and I am honored to present alongside Dr. Herbert Oye, a vascular surgeon at Raleigh General, and my fellow medical student, Temi Njideaka Kevin. So our presentation today is on the topic of common carotid to internal carotid artery bypass as a treatment of carotid artery stenosis. So let's begin with a brief overview. Next slide, please. So carotid artery stenosis is defined as a narrowing of the carotid artery, commonly at the bifurcation. This condition is associated with several risk factors such as advanced age, smoking, arterial hypertension, and diabetes mellitus. So next slide, please. Clinically, patients with this condition may present with symptoms like TIA or transient ischemic attacks, ipsilateral amaurosis fugax, or contralateral weakness, or some sensory deficits. Diagnostic imaging techniques typically include carotid duplex ultrasound, CT angiography, and MR angiography. Next slide, please. So the treatment approach for carotid artery stenosis involves lifestyle modifications, medical management, and carotid revascularization. So revascularization methods seen on the slide include endarterectomy, balloon angioplasty, and bypass grafting. So depending on the severity and location of the stenosis. In this particular case, the decision for a bypass procedure was essential to the patient's successful outcome. So next slide, please. So the patient in our case is a 67-year-old male who presented with left carotid stenosis. His history includes TIA, transient ischemic attacks, multiple near syncopal episodes, dizziness upon exertion, and right-sided lower facial numbness and neck pain that began 10 months prior to presenting to our clinic. So notably, his past medical history includes coronary artery disease with previous coronary artery bypass grafting and multiple stent placements, nearly over 20 stents, along with hypertension, hyperlipidemia, and type 2 diabetes mellitus. So during the physical exam, carotid bruit was identified on the left side of his neck with an absent radial pulse on the left extremity. Next slide, please. So following his initial visit, a CT angiography revealed a 75% stenosis of the left internal carotid artery with 2 penetrating ulcers. So this raised concerns for a TIA and stroke. So the decision was made to proceed with a carotid endarterectomy. Notably, a previous CT angiogram about 10 months earlier showed 70% stenosis on the left, in the left internal carotid artery, and 55% on the right. So we focus on the left mainly. So now I'll hand it over to my colleague here, and we'll talk about the details of the operative procedure.
Thank you, Aslam. So I'm just going to go ahead and talk about the procedure that we did and what we encountered. First, we anesthetized the patients. This procedure was with general anesthesia using propofol. And after that, we prepped the patients using ChloroPrep and then draped the patients. And then we had a timeout. And then the procedure was started. Now, in the procedure, the main idea is to locate and identify the vessels because we don't want to go cutting what we're not meant to. So we identified the right common carotid artery, the superior thyroid artery, external carotid, and the internal carotid artery. And then after that, we clamped the internal common and external carotids. And the reason why we clamped was to avoid blood loss during the procedure. The reason we're able to clamp, because that's one of the major source of blood supply to the brain, is because the brain has collateral blood supply. So although we clamped the left carotids, the right carotid and the vertebral arteries posterior are also supplying the brain. And after clamping them, we made an incision on the internal carotid and took out the plaque. Now, on the left picture, you can see the left internal carotid that we were able to identify and cut open. And if you remember in the CT scan, the CT angiography, one of the things that we saw were two penetrating ulcers. And that raises huge concerns for TIA because clots can then go all the way to the brain. And in here, we can actually see, I'm not sure if I hope you're able to see, but we can see the ulcers in the picture on the left. After we took out the plaques in the blood vessel, it was pretty big and it was extensive. It went from the common carotid and actually went into the internal and external carotids as well. And that's what's on the picture on the right. Next slide, please. After this, the blood flow was a lot better through these vessels after we closed up the vessels, by the way, with the patch. And the blood flow through the internal common and external carotids were a lot better. But then while Dr. Oye was suturing the vessel, there was a lot of bleeding, and this was primarily because of the poor caliber of the vessel. And the vessel was clearly narrowed. So there was a concern for if we were to leave that the way it was and close it up, the patient could eventually have a stenosed artery again. So we had to make a decision mid-surgery, mostly Dr. Oye making the decision on if we wanted to ligate, so basically cut the left internal carotid, and this way you're not going to have, or you have pretty much zero chance of any clot going through that vessel. Or we could use a bypass. And in this patient, we opted for a bypass, basically going from the common carotid to the internal carotid and basically going around the diseased area. And that's what we opted for. Now to do this, we got the Gore-Tex graft, and initially we attached the upper portion of the graft to the internal carotid artery, distal to where we made the initial incision. Next slide, please. After we did this, then we did basically an arteriogram to see how the blood flow was through the internal carotid. And we did this through the stump of the graft that we had just attached. And in the picture on the left, this was initially when we basically did the arteriogram, and you can see that superiorly, there was still considerable stenosis in the internal carotid. Now, at this point, we then put in the balloon for the balloon angioplasty, and then we used a 4x40 advanced balloon, and we basically inflated it for 30 seconds at 5 atmospheric pressure. And the very idea of this is to allow more blood to be able to flow through the vessel. And you can see that after we did this, it pretty much did its job because the blood flow through the internal carotid was a lot better. After this, we were satisfied, and we basically attached the other part or the lower part of the graft to the common carotid. And this way we're able to bypass the diseased region of the internal carotid. After this, then we closed up, and Dr. Oye mostly closed up, and there was no more complications with the procedure. This was meant to be roughly a 1-hour procedure, but because of all the things that we encountered, it ended up being about 4 hours. So it was a lot longer than it was meant to be. And yeah, there are a couple of things I will explain in the future slides. Next slide, please. Now, after the procedure, post-op patient did well. There were no significant post-op findings, and we did a repeat CT angiogram after the procedure just to check for if there was now better blood flow to the brain. And the good thing is there was. So there was better blood flow through the common carotid, internal, external carotid, and the bypass graft as well was patent. So this was what we hoped for through the procedure, and thankfully it came out to be that way. Next slide, please. So to conclude, the high-grade carotid artery stenosis is typically treated with endarterectomy. So that's typically the first thing that you want to treat, especially if the patient is symptomatic and they're able to go through the procedure. However, in this case, we needed to do more than that. So there are usually three options if you're going to go through the revascularization. Like my colleague explained earlier, there's the endarterectomy, which is what I just explained, cutting the vessel and taking out the plaque. There is the balloon and stenting, which is putting a balloon and inflating it to allow more blood to go through. And the bypass, if there is recurrent occlusion or the blood vessel is just really diseased, you can just bypass that area with the graft. In this case, very interesting case because we had to do 3 on 1 patient. And ultimately, the patient benefited from the left common carotid to internal carotid artery bypass. And this highlights the importance of the cardiac artery bypass as a treatment method when unhealthy vessels are encountered mid-procedure, because we actually did not start out planning to use any graft, but then in the procedure, we saw how diseased the vessel was and we had to do that. And these are my references. Next slide. Next slide, please. Thank you very much. And if you have any questions, please feel free to ask, and my colleague and I will try our best to answer the questions. If not, then Dr. Oye will bail us out.
Nice job. Thank you, gentlemen. Appreciate it. Great job. Any questions from the audience? Any questions? No. Okay. So again, it's important. I did blood endarterectomy here in Bielsa about maybe 5 years ago. The first one we did in Bielsa. Then the patient who had was a friend of a friend, brother of a friend of mine. We both went to pharmacy school together many years ago. So he had a problem, and his brother wanted to send him to the U.S. And around the time Mr. Trump was president, so couldn't get a visa. So we had. And I was coming to Bielsa, and I just went ahead and did the surgery here at Bielsa Special Hospital. He did well and went home right here somewhere between here and Port Harcourt. And so he's doing well, still is doing well. So it's the commonest surgery performed in vascular surgery is carotid endarterectomy for many years. It was for many years. Now, the other type of surgery that we do now is called TCAR, transcarotid artery revascularization, TCAR. That's up and coming. And the advantage of TCAR is you don't have, you still make a small cut, but then you have put the wires in the balloons and you put a stent in. But before you do that, you're able to reverse the blood flow away from the brain so the clot does not go to the brain. When we do standard carotid endarterectomy, which we did in this case, in which doctors are able to recount it, once you expose the artery, you look at the internal, the common, and the external. We clamp internal, common, external in that order, ICE. So the reason for doing that, you clamp the internal artery first because that's the artery that takes blood to the brain. If anything escapes, it's going to go to the brain through the internal normally. So you clamp that first. Then you clamp the common, you clamp the external, ICE. Then you open the artery, then you take the plaque out, like you've seen on that picture that the doctors presented. That's a lot of plaque that came from somebody's neck. And we have other persons that have a lot more plaque than that. But that's a standard plaque design that normally occurs. Then after you do it, if the person has a generously large artery, you can really just close the artery directly without patching it. However, women tend to have smaller arteries than men. And also, in that case, you can use a patch. A patch, you could use the patient's vein. You can take a piece of vein and make a patch and make that artery a little larger, but it takes more time to take a piece of vein from a patient. Nowadays, we have some materials that we can use to, in place of the vein. You can use Gore-Tex. You could use what we call HemoShield graft or patch. And also, you can have some biological grafts made from cows and pigs. You can also use to do that. Again, for the advantage of open carotid endarterectomy, it's less costly. You're just opening, clamp, open, take plaque out usually. When you do the TCAR, TCAR's advice for patients who have high-risk patients. You know they have had a stroke. They have their other side's not very good. So you really want to protect the brain during the surgery so they don't have a stroke. So TCAR is a good option. TCAR is also very patient dependent, meaning the person has to be a certain age level, usually around 80. We push the envelope a little bit in certain patients. But then the people have heart issues also. will sometimes be candidates for TCAR. One of my young students presented a paper recently for publication on a 37-year-old lady, just had she was pregnant, had a baby, and she had postpartum bleeding that was massive. And after the postpartum bleeding, after she was discharged from home after delivered baby, she came back with postpartum bleeding, and she lost so much blood, almost 4 liters. So she had to have emergency hysterectomy performed. So while she was in the hospital, she complained of massive headache, and then the headache wasn't going away. So a CAT scan was done. A CAT scan revealed she had what we call carotid dissection. There was separation or tear of the carotid artery. What doctor just showed here was a tear of that artery that was causing her to have pain. In addition to tear, she had a 75% blood clot also within that tear. So that was a candidate at that time. Even though she was young, we felt strongly that she didn't have a plaque per se, but she had a dissection of blood clot. So we felt strongly that that patient needed to have treatment with the TCAR technique. So we offered that TCAR technique to this patient who was only 37 years old, and she did really well. She went home within a couple of days after the surgery, and she did well ever since. So again, identifying the best surgery for the patient and being skilled to offer that care is important. And if we don't have the resources to provide that care for the patient, our ability to send those patients somewhere so where they can access that care is important. And that's the reason why we are presenting cases like this for us here in Nigeria. Okay, thank you, gentlemen. Nice presentation. We'll hope to see you soon. Thank you. Nice job.
Thank you all.
Thank you.
Okay, who's Nicolina? Okay. Okay, our next presenter is Nicolina. Okay, very good. This is that last one.
Hello, can you hear me?
Nicolina, can you hear us?
Yes.
Yes,
hear
I
us?
can hear you. Yes. Hello, Dr. Oye.
Hey, can you hear us?
Yes, I can hear you.
Let me tell them a little about you first. So she's going to be presenting to us today. Again, the purpose of this conference is to empower young doctors, the future of medicine, both here in Nigeria and outside Nigeria, to take what their calling is in healthcare seriously so they can be able to change the lives of their patients. So she is going to be talking to us today, and the floor is yours about thoracic abdominal aneurysm, correct?
Yeah, to talk about aneurysm repair. So if my presentation could please be pulled up, it's called the Clinical Impact of Thoracic Endovascular Aortic Repair in the Management of Thoracic Aortic Diseases, please. Thank you. Perfect. So I'll be discussing this article that is from a recent publication from the October 2024 issue of the Journal of Endovascular Therapy, written by Milano al. And like I said, it's titled The Clinical Impact of Thoracic Endovascular Aortic Repair in the Management of Thoracic Aortic Diseases. So next slide, please. So thoracic aortic diseases, or TADs, they are commonly classified usually as historically as either aneurysms or aortic dissections. However, there are also other subtypes that exist, but those are the two most common ones. And risk factors for TADs include an older age, male sex, smoking history of hypertension, and family history. Those are kind of the main ones. And thoracic endovascular aortic repair, or TEVAR, it's been shown in the literature historically to be superior to the open surgical approach by reducing overall morbidity and mortality rates. So it's been shown to have lower rates of spinal cord ischemia, respiratory failure, renal insufficiency, cardiac complications, the need for transfusions, paraplegia, and also this procedure is associated with shorter ICU stays. However, there are obviously also risks for the procedure, and these include stroke, spinal cord ischemia, device failure, unintentional great vessel coverage, access site complications, renal injury, endoleaks, guide wire injuries, retrograde dissections, and aortoesophageal and aortobronchial fistulas. So the objective of this study was to determine and describe the outcomes of TEVAR for patients with complex TAD. Next slide, please. So this was a retrospective review of a prospectively collected database in Colombia, and the subjects were patients above the age of 18 who underwent TEVAR between February 2012 and March 2022 in Colombia. And there were 66 patients that ended up being included after all the exclusion criteria and inclusion criteria were implemented. And then preoperative data included patients' demographics and comorbidities, including their renal function preoperatively and the type and the size of the TAD that they had. Operative variables included the vascular approach that was utilized, the type of anesthesia used, the amount of intraoperative blood loss and the operative time, and then the surgical outcomes being looked at was the requirement of reintervention, if ICU stay was required, the length of hospital stay, and then the morbidity and mortality rates at 30 days follow-up. And then there were statistical and multivariate analysis done with, it was shown to be, things were shown to be statistically significant if the p-value was less than 0.05. So for the results, in this study, 60.61% of the participants were male, and the mean age of the participants was 69.24 years. Comorbidities included type 2 diabetes, arterial hypertension, and coronary artery disease, as well as smoking or nicotine dependence, which are all risk factors for TAD. And the types of TADs that were documented in these patients, majority or about 68% were aneurysms, 4.55% were ulcer related, 7.58% was intramural related hematoma, and 1.52% was trauma related, and then 30.3% was aortic dissection. So next slide, please. So for the other results, so the mean hospital stay for these patients came to be about 18 days, and ICU was required for most of the patients, for 98% of them, with about a 3-day stay. And then the mortality rate at 30 days follow-up in these patients was 10.61%. And this was secondary to acute coronary syndrome, pneumonia with ventilatory failure and sepsis, and endoleak. And then the reintervention rate was 21.21%, and the morbidity or complication rate was 15.15%. And then the 1-year survival rate after the procedure in these patients was 77.7%. And then the endoleak rate was 10.61%. Next slide, please. So the patients in the mortality group after the analysis, they showed an increased age compared with the non-mortality group. So it was about 75 years in age compared to 68 years in age, and it was statistically significant. And then in terms of when looking at the mortality, there was no relationship between the types of TAD or the size of the aneurysm or the renal function pre-op, the procedure with mortality. It wasn't associated with it. And then for the length of the hospital stay, the presence of having an aortic ulcer or an intramural aortic hematoma, it did have a significant relationship with increased hospital stay length. So if you did have a hematoma or an ulcer, the patients were more likely to have to stay at the hospital longer. And then for morbidity, so with a p-value of 0.03, females did have more complications compared to male patients, but renal function was not shown to be related to morbidity. And then next slide, please. So interesting, they also took BMI into account as well, and they did BMI under 18.6 as underweight, BMI over 30 as obese, BMI 25 to 29.9 was overweight, and 18.5 to 24.9 was normal. But the results had shown that underweight or BMI less than 18.6 had increased complications and endoleaks with a p-value of 0.00. And then after the analysis was conducted, it showed that underweight patients had a 6.7 time increased risk of complications and an 11.4 time increased risk of endoleaks compared with the higher BMI groups. And there was no relationship found between endoleak and renal function. So next slide, please. So the multivariate analysis results basically showed that increased intraoperative blood loss and male sex was statistically associated with increased mortality, and intramural hematoma was statistically associated with increased hospital stay, and low BMI or underweight patients was statistically associated with increased morbidity and the presence or development of endoleaks. Next slide, please. So this article was pretty significant because TVAR has been shown to be the gold standard approach for TAD treatment, as there are lower rates of morbidity, mortality, having to stay in the ICU, as well as less blood loss has been found. But it was significant because it found that endoleaks occurred more frequently in patients with lower BMI, where there is limited literature evaluating the association between BMI and endoleak occurrence. So more research does have to be done on that, and it showed that there's no significant relationship between aneurysm size, renal function, and endoleaks, which has been debated among the literature that has shown different results about whether renal function does impact the post-operative outcomes of TVAR surgery. In this study, too, only 39.1% of the patients were female, so women were underrepresented in the study, but that also has to do with the fact that TAD is more common in males. And there was no significant association between sex and the hospital stay length, which was different from previous studies, which some studies had shown that females had to stay longer at the hospitals. And this study had shown that women had more complications than men. The Global Registry for Endovascular Aortic Treatment study had shown kind of the opposite, that women had less complications than men. So there is also debate among that literature. And then in this study, males were statistically associated with higher mortality compared to females, which this was also been debated among literature and has had differing results in different studies. Intramural hematoma was not associated with increased mortality, which more research needs to be done on that because the data is limited for that as well. And then, so what was documented, what was shown here too, again, was the obesity paradox, which was first documented in about 2008 by Galal et al. As well as Lavier et al. In 2009, which which is basically kind of a paradox because in most cases for surgical procedures, obesity is normally related to increased rates of postoperative morbidity and mortality. But this paradox has been noted in specifically vascular pathologies where patients with increased BMI have shown better prognosis for vascular pathology, such as arterial hypertension and PAD and TAD. So the strengths of this study, so it was a long-term follow-up, a 10-year follow-up on this study, and it was conducted in Colombia, so it used the Latin American population, which a lot of times is underrepresented in the literature. And significantly, it does support the feasibility and safety of TVAR in obese patients. It's not saying, obviously, to become obese or overweight to get better outcomes, but it's showing that in patients that are already obese and they might be a little hesitant, and when doctors are explaining to them the risk, it's showing that they possibly might not be at an increased risk for postoperative complications, which was, historically thought in obese patients undergoing these surgeries. And then it also suggests that in emergency patients, kidney function was not statistically associated with increased morbidity or mortality. So it is also can be safe in patients who have kidney failure or kidney issues, which is very common. Limitations of the study, obviously it was a retrospective study and there was no control group like an open surgery group, and it was a small sample size of 66 patients, but that was also because it was a 10-year follow-up, so they lost a lot of patients to follow-up. So next slide, please. So conclusions of the study is that TVAR is a feasible option for patients with TADs, and renal function in this study was not related to postoperative TVAR outcomes. And it showed that underweight patients did have an increased risk of overall morbidity and an increased risk of developing endoleak risks. And it showed in this study particularly that obesity was not associated with poor postoperative TVAR outcomes. And obviously further prospective studies are needed and more research is needed in this area. Next slide, please. And these are the references from the article and also from the research I had done into the subject. So that's everything. Thank you, everyone. If you guys have any questions, you can ask, but that's everything. Thank you.
Nice job, nice presentation. For the audience, when we talk about abdominal aneurysms and or thoracic aneurysms, typically it's that bulge of the artery that's in the chest area. So it can start in the collarbone area, and it can sometimes go all the way down to your belly, and sometimes to your groin area, and cause some problems. Typically in the textbook would tell you in Nigeria, for example, you don't have a lot of thoracic abdominal aneurysm issues. That's not true, because we have a lot of patients in Nigeria walking around right here in Bielsa that have thoracic abdominal aneurysm, don't even know they have it. They'll just drop dead. And all of a sudden, oh, Uncle Joe just died, but that's what killed him. Okay, so it's a problem. So again, how we figure that out, that they have a problem, they typically have some kind of discomfort. They get an X-ray for something else, and they find the aneurysm, that the artery is bulging, and then they get a CAT scan to see it's a problem. The key number to remember is 5 cm, okay, 5 centimeters. If your artery is less than 5 centimeters, you're fairly okay. Most aneurysms don't rupture or burst before 5 cm normally. When it's more than 5 cm, the risk for rupture goes up. If the aneurysm is below the level of the kidney arteries, then again, patients would have what we call infrarenal aneurysm. And for board exams for the doctors here, 90 to 95% of patients have infrarenal aneurysms. And again, if I can bet you, if I take 100 people in Bielsa and check them out, a few of them will have an aneurysm. Walking around Bielsa, don't know they have one. And all of a sudden they ruptures and they die. So again, that's the benefit of health check. So that way you even before you get sick, the aneurysm don't occur usually in the United States they start to worry about that from age 50 and above. Okay. In Nigeria, we see our people much younger, in their 30s and 40s, they have aneurysms, especially in the chest. Again, it could be an inflammatory problem in this climate. It's a problem. One of the things that the study that she mentioned about showed that the stay in the hospital is about 18 days. In the US, you're not going to stay in the hospital for 18 days, that's for sure. After a few days, they're kicking you out of the hospital because you're spending too much money. You have to go out. So that's Colombia, where that study was done, would reflect what is here in Nigeria, for example. So if a study like that, if TIVA, which is a nice way to treat aneurysm without opening the person's chest, you're only going from a person's groin or sometimes the arm to put that stent within that aneurysm treated person. Number one, it's easy for the patient to recover. You don't split his chest, the pain is less. Okay. Number two, they're able to go home sooner. When she talked about endoleak, see, you have that artery, the aneurysm, whatever the aneurysm is. It's like putting a new pipe instead of an old pipe. So that you have that aneurysm and there's a leak or somewhere it's leaking. When you put, or even not leaking, you put a pipe inside it to prevent that aneurysm from expanding further. So once you do that, that's a TIVA in the chest area. Once you do it in the belly area, it's called EVA. So again, sometimes even after you've done that, the natural native arteries of the aneurysm continues to leak some blood into that sac. And that's where you can get what we call endoleak. The endoleak, there are several types of endoleak. Type 1 endoleak is the way when you connect that and put a graft in, the graft must attach to the top portion, stay sealed, okay? Or the bottom portion stays still. It's a tube. If the top portion is undersized, meaning, let's say the size of the top normal artery is 30 millimeters, and you put a 26 millimeters stent, what do you expect? It's not going to close it, right? The size is 30, you put something smaller than 30, it's not going to seal. So you have an endoleak. That's a type 1 endoleak. That is not going to go away. You have to fix it. You have to get something that's more than 30, like 34, 35, and to put up there to seal that, okay? Now, type 2 endoleak is where you've cured the person's problem. The top is sealed, the bottom is sealed, but they're still leaking. The aneurysm is still getting bigger. So that could be coming from the vertebral arteries. In that case, that's type 2 endoleak. Most type 2 endoleaks, especially if it's in the belly, will go away within 6 months. But if they keep building up, not getting better, then the radiologist can find unique ways to put special sponges or coils, kind of slow it down. The worst case scenario, if it's not getting better or they have too much pain, you may have to remove the graft. Then type 3, the fabric material that you put sometimes may have a problem and be porous and all that. So that's important. Dr. Nicolina did a fantastic job presenting an article, and that's what I want our young doctors here to do. You should be able to present like all the young doctors you've seen on the other side of the planet, presenting medical and surgical items in a systematic way that makes sense. So the goal of this exercise is to ensure that we share information not only from the United States, but also share information from Nigeria to the United States. There are certain things that we do well in Nigeria that we don't do well in the United States. I'll give you an example. Women here in Africa, most African women have fibroids, okay? American doctors cannot treat fibroids well. They will take your uterus away. 1, 2, 3 is gone. Hysterectomy. It's no time wasted. They'll take it out. They're not going to play around with you. They don't know how to do myomectomies, okay? Nigerian doctors particularly are experts in myomectomies. They will do a great job and spare uterus. So if you're young, you want to go to a Nigerian doctor, okay? If you have a fibroid, okay? We've had patients come from the US. I sent a nurse. A nurse is from the US. I was talking to her in passing. Said, by the way, oh, she's like 39 years old. She's about getting divorced or something, and their doctor's about to take my uterus away. So, okay. Have you heard about myomectomies in Nigeria? At the Bilateral Specialist Hospital, we have skilled doctors that can do that surgery for you. So I convinced her. She flew from the US, came to Bielsa, had that surgery done at Bielsa Special Hospital, and went back to the US. That's what we're talking about, medical tourism, okay? Tourism that expands what we can do well, okay? What I'm trying to do is not only that, but also bring technology from the other side that I've done for over the years. I've been doing this for many years. Since I've been in training from medical school since 1985 till now. I've been doing all this. So I have a wealth of experience, and I wanted to bring that experience back to Nigeria. And also particularly to Bielsa, because this is a beautiful hospital. It has all the things you need to be a premier center that we can compete with most other hospitals in the country and outside the country. Like I stated before, we had a patient that came from Mori, was treated here in Bielsa Hospital, went home the next day. Like I would do it when I step in the operating room in Bielsa Special Hospital right here. I can do surgery like I'm in the United States. I'm confident I can do it, okay? So we would need to keep working and talking with the powers to be, that they understand that we are at the unique point in our history. Bielsa is just a young state. We can do better, okay? So we can bring the technology here all the way, but again, we need that the activity or the actions of our doctors. We have excellent doctors here. Dr. Dave's here with us, an excellent doctor. I can trust Dr. Dave's recommendation. If he calls me in the US and says patient has A, B, C, D, I can trust his care. Okay, the question is, if somebody else calls me from Nigeria, do I trust them? That's the key. Okay, so I want the young doctors, for me to trust you, you have to be like Dr. Dave. See what I'm saying? So you have to do the right thing. And the nurses, you call the doctor needs to trust what you're telling them. So when you see a patient on the ward and you think the patient has a problem and you're communicating that information to your doctor or to me, the way you present that information, you're being concise, you're not going all the way, Tell me exactly what's wrong. So in my mind, I can crystallize what you're seeing and say, oh, by the way, this is an emergency. So if you're talking to Dr. Dave about he's at home, and you tell him something about your patient have this, what's going to make Dr. Dave say, well, this is an emergency, this is urgent, I have to get into my car, start driving to the hospital. It's the way we want this hospital to operate. So everybody's sufficient, from the nurses to the doctors to the pharmacists, everybody is sufficient. That's the way it should be. I want to make sure we're able to replicate the good work that we do in the United States here in Africa. Okay, so we've made alliances, we've met many friends, many doctors in different specialties in Nigeria, and we collaborate. We want the Bielsa Special Hospital to be able to collaborate with other doctors in Nigeria. For example, if I'm not in Bielsa by any means, and you have a complex case, we can simply call on colleagues that we know can do a nice job. They can come to Bielsa and fix the patient's problem. So that's all called collaboration. So again, that's important. Dr. Nicolina, nice talk. We appreciate you being here today. Thank you so much. And I'll see you on the other side of the planet. Thank you.
Thank you, Dr. Oye. Thank you for having me.
In closing, I want to make sure that we improve healthcare. We advance healthcare, particularly because vascular surgery is important, particularly if you notice through the whole discussion, we talk about every person thing we talk has to do with circulation. I didn't talk about veins today for the legs, but we talked about veins going to the chest. We talked about stents, put stents in the chest. Imagine putting a stent in your chest. If that stent ruptures, the vessel ruptures, you're dead. So it takes a lot of skill for you to be able to go in there, put a wire in somebody's chest, and put a balloon and crank the balloon off and hope it doesn't burst. If it bursts, they'll be dead in 2 minutes. Okay, so this is a skill set that we can bring to Nigeria. Again, we have to, that area of surgery that in vascular surgery particularly, it's important because most of the patients here in this room would have relatives, family members that are getting advanced in age. They will have a problem, stroke, heart attack, leg problem, wounds that don't heal. Those are the things they will have. So you need to know about this discussion and be able to tell them to go where they can get help. just go to the pastor and praying is good. But when your problem is beyond the pastor, better seek help because you will lose your leg. You will have the wrong pastor, you will lose your leg. I just say it's spiritual attack. Okay, I have heard that before. Okay, but you lose your leg if you're not careful. So again, it's okay to seek have a pastor pray for you, but at the same time, be proactive. Go where you can be treated. Okay, and again, one of the things we also want to talk about again is medical tourism. I talked about we need to make sure Bielsa becomes a center for medical tourism. So we'll work hard at making sure that becomes a reality. That was the dream or the expectation of a prior governor of the state that initiated the process. We want that process to continue, and we'll have to reinvent that process again. And again, we've had some interesting talks, and we've empowered some young doctors across continent. I trained them from all parts of the world: Canada, India, Pakistan, Nigeria. So they all come. We train them. Okay, but again, we want to be able to not only train them there, because not all our doctors can go there. We need to make sure we have a good place here in Bielsa that we can train young doctors. Okay, so I'll at this point give the microphone to Ms. Cynthia Oye Isang if she has any last words, and we'll conclude this message.
I thought we're going to keep that going. Thank you very much, Dr. Oye, and to the amazing doctors in West Virginia and everywhere else. Thank you. I know it's still morning hours or early afternoon for you, so we're going to wrap up soon so you can get back to work. We are winding down here. It's almost evening already. But I believe that everyone who's participated online, virtually and offline here in person has gained something. Whether you're a clinician or a non-clinician, the knowledge that has been shared today, you should find useful to you. At least you know things to do to prevent yourself from, getting certain hooked up by certain conditions, health conditions, or, if you already have the situation, you know what to do, right? So let's not snooze on the information that we've gained and try to be healthier. Indeed, Bielsa is a glory land and glorious things can come from here, but we have to make it happen. As Dr. Oye has rightly said, the vision today is what it was 9-10 years ago, right? For us to, first off, see how we can significantly improve the healthcare in Nigeria, at least contribute towards that. And specifically, I don't feel too good, see how we can reduce amputation. Some of those amputees we see, they probably didn't have to lose those limbs that they lost, but because one, there was a knowledge gap, one, two, maybe lack of access to care, the right care, but we can change that narrative. And we have certain things in the pipeline, one of which is to see how we can work on delivering surgical tech education, right? It's in the pipeline, but this is us opening up to say, if you're a clinician or a physician who's interested, or non-physician who's interested in developing, surgical technology skills, please come forward after this with your names to the office so that we can, identify these people and start to work on these things. Before these things are instituted, we can, do a lot of learning via telemedicine or, leveraging on technology to make sure that these things are done, right? It's not magic, it's not rocket science. It's interesting how you go on Google today and say endovascular surgeons in Nigeria. I mean, I can dare somebody now to do that and let's see how many names will pop up. I doubt if you would even have 2 names pop up. Now we have one renowned person who's our own, who's Bielsa, and when everyone, when I'm in West Virginia, I can do shakara like we'll say, oh, that's Dr. Oye's sister. It rubs off just because of what he does. No cap, like they say, right? But where Dr. Oye is not here, who's the next Dr. Oye? Or who's the next closest thing to Dr. Oye? it can happen. We can have someone who's, more fantastic at this, but you need to, come out. But lest I say too much, thank you very much for being here. This is something we do every year. This was supposed to be low key, and I'm impressed at the turnout. So I guess we're going to blow up the 8th edition, I guess, or the 8th. So that's it. Thank you very much. Wish you all an amazing weekend. Stay healthy and keep your limbs safe. Yep. Thank you. Thank you, guys.
Bye.
Thank you. Have an amazing one.
Thank
Bye,
you.
Krista.
Thank you,
Tell
Dr.
them
Thank you.
Thank you for having
Thank you,
us.
everyone.
Thank
Thank
you,
you.
Doctor.
You know, reach everybody.